Hi, everyone, and welcome to the Improvement Action Network. We're part of the Wisconsin Hospital Association, and this is an introduction to sepsis. This is a brief 5-minute video. It's not designed to be comprehensive, and we are always available if you have further questions. Basic treatment of sepsis involves early fluid resuscitation, early administration of broad-spectrum antibiotics after blood cultures have been drawn, and then extensive laboratory analysis, including serum lactate, to screen for end organ damage. This is all in the context of source identification and control. Intra-abdominal sepsis from a perforated appendicitis, for example, is going to need surgery. An infected central line will require the line be pulled. Your garden variety urosepsis therapy will be broad spectrum antibiotics with excellent gram-negative coverage. So it's easy to get into the weeds in all of this. We have a separate video addressing treatment as outlined by the CMS SEP1 core measure. And this table above is just going to get the conversation started here. So, sepsis is a state of critical illness caused by the body's overwhelming and life-threatening response to infection, and it culminates in tissue damage, organ failure, and death. It can be difficult to predict, diagnose, and treat, and patients who develop sepsis face higher healthcare costs and longer treatment courses, in addition to having an increased risk of complications and higher rates of in-hospital mortality. If we think about the definition of sepsis here, I love this old Greek definition, a state of putrefaction and decay. And that's really what we're talking about. We're talking about bacteremia in the bloodstream, an infection that started off local, spreading to other parts of the body. You can get sepsis from viral infections and fungal infections, but most of the time we're talking about bacterial infections. And this little cartoon on the top left here just shows some of the common places you're going to find sepsis. So, group A strep from strep throat, pneumonia, community-acquired pneumonia, cellulitis, obviously, urinary tract infections, and then things like meningitis and more rare entities are still on the menu as well. Some quick facts here. Sepsis is becoming more common. It's often fatal, and we are seeing positive trends in treatment. So the estimates of incidence of sepsis worldwide vary, but they range from 66 to 300 per 100,000 in the population in the developed world. There is consensus that the incidence is increasing, and it's driven by an aging population with multiple comorbidities, increased use of immunosuppressive therapy, and high-risk interventions. So chemotherapy was one example of that. Mortality estimates for sepsis range from 27 to 36%. So of all comers, 1/3 of sepsis roughly is actually fatal. And the risk of death from sepsis has been falling over recent decades despite increased incidence, likely due to improvements in care. So even though we are seeing more sepsis, we're getting better at treating it. The Surviving Sepsis campaign has been a key influence for sepsis care. It's a unique international collaboration for quality improvement that was established in 2002 by the European Society of Critical Care Medicine, the International Sepsis Forum, and the Society for Critical Care Medicine. The SSC, or the Surviving Sepsis Campaign, has developed evidence-based guidelines for the management of sepsis, and those are the guidelines that we're going to be using in this presentation today. Now, if we look locally, these epidemiology studies come out every decade or so, and so the last study that we have is from 2010, and it showed that Wisconsin is actually doing pretty well in terms of sepsis-attributed deaths by state. So we are number 8th, lowest or best in the nation. That is often the case with Wisconsin. We have pretty good access to care. We have a cold climate where you're having a few fewer sources of infection. And if you look at it, there's probably some social upstream behavioral determinants of health that also contribute to sepsis. Much like the Southeast is the stroke belt, it also tends to be the sepsis belt in the U.S. And so in our state, we have 50.3 annual deaths per 100,000, or about 203,060 Wisconsin sepsis deaths per year. That being said, we can always do a lot better, and if we look at our neighbors to the west in Minnesota, they're doing quite well, and so there's a lot of room for improvement still. We're getting into definitions here, so let's address the elephant in the room right off the bat. There is a new definition of sepsis, and we are intentionally not using it. The third international consensus definitions for sepsis and septic shock were published in February 2016. The new definitions are intended to improve the clarity of the old definition, which basically has this term severe sepsis, which is a very non-specific term. And so we're trying to get more of a regimented way of describing it that's based on objective things and not the more subjective term severe sepsis. This time next year, we will likely be talking about the new QSOFA score, but for now, we will still use the SIRS criteria, which is the basis for the CMS SEP1 core measure. For more information on the QSOFA score, we have a separate 5-minute YouTube video comparing and contrasting SIRS criteria and QSOFA. So if you want to check that out, you're certainly welcome to. Right now we're talking about SIRS. That's the classic definition of sepsis and the one that the SEP1 core measure is based on. Systemic inflammatory response syndrome is a pro-inflammatory state that's usually, but not necessarily, caused by infection. Fever of more than 38 degrees Celsius or less than 36 degrees Celsius will get you 1 point. A heart rate of greater than 90 beats per minute is another point. Respiratory rate greater than 20 or a PaCO2 less than 32. And then abnormal white blood cell count greater than 12 or less than 4,000 or greater than 10% immature band forms. So if you have 2 of these SIRS criteria plus a source, that becomes sepsis. If you add on signs of end organ damage, EKG changes, altered mental status, elevated lactate, there's quite a few of these surrogates for end organ damage, then we fall into the severe sepsis category. And finally, if the systolic blood pressure drops below 90 or the mean arterial pressure drops below 65, now we're dealing with septic shock. In many ways, these classifications are kind of arbitrary, but they become important when we start implementing sepsis bundles to comply with the CMS SEP1 core measure. We'll touch more on this in a future lecture, but one key example is the 30 cc per kilogram bolus that is supposed to be ordered in patients with severe sepsis, and vasopressor medications are supposed to be initiated when patients are in septic shock. So you may have a patient who meets sepsis criteria but does not meet severe sepsis criteria, and in that patient you do not necessarily need to administer a 30 cc per kilogram bolus. That's just an example of why this categorization is used and why it makes clinical sense. SIRS in general is a inflammatory response to the microorganisms of the invasion of normally sterile tissue of the body. So SIRS is basically part of our body's natural defense mechanism. The inflammation that occurs in SIRS is the body's response to nonspecific insults that arise from chemical, traumatic, or infectious stimuli. So SIRS criteria is broad. It's not specific to sepsis. There's a lot of other states that can cause this cytokine release. Cytokines are small chemical messengers that tell our immune system to spring into action, and a reasonable amount of cytokines release actually promotes growth factor stimulation, the recruitment of macrophages and platelets, and it creates this redness, pain, and swelling that are associated with normal healing. So if you get a scrape on your arm, you get a cytokine release, you see redness, you see warmth, you see tenderness, and that's how it's supposed to be. The body then releases a subsequent anti-inflammatory cascade to counter the initial cytokine release that basically controls that immune system reaction so it doesn't get out of hand. With a large bacterial insult, homeostasis may not be restored, and the cytokines will just continue to seed into systemic circulation, causing destruction rather than protection. And from that point on, we get a humoral cascade, activation of the reticular endothelial system, capillary leak, third spacing of interstitial fluid, and finally end organ dysfunction. Now, for those of us who dozed off during pathophysiology, these are my definitions of sepsis down below. You have sepsis with a lactate of greater than 4. That's 30% mortality right there. If you add a sepsis with a blood pressure less than 90, that's 36.7% mortality. And finally, low blood pressure and an elevated lactate in the context of sepsis has a 46% mortality. So, I'm an emergency physician. The reason this is so important is because these are some of the sickest patients in your ED, and they don't always appear as sick as they look. And so using the SIRS criteria and these definitions of sepsis, we can sometimes catch very serious illness and intervene quickly before it becomes out of control. Now, we kind of touched on this, but the presence of systemic inflammatory response syndrome, or SIRS, plays an important role in identifying patients with infection. And some clinicians grumble about the poor sensitivity of the SIRS criteria, But SIRS is really a screening tool that is designed to have false positive. That's kind of the point. We are casting a wide net intentionally to avoid missing occult sepsis. That being said, approximately 10 to 12% of patients with sepsis in intensive care units did not have greater than 2 SIRS criteria. So even when we're using SIRS screening, we're still missing 1 in 8 cases of sepsis. Screening for SIRS criteria does not allow us to turn off our brains and feel confident that we've ruled out sepsis. We need to rely on our detailed physical exam, our frequent reassessment of vital signs, and adjunct information like the lactate lab to help us pick up those tough to recognize cases. If you look at this Venn diagram here, this basically just highlights not all infections are sepsis, not all SIRS criteria are sepsis. And if you look at that middle pink area that represents sepsis, you see that there are bacterial sources, parasitic sources, fungi sources, viral sources. And so sepsis is a very complicated beast. A lot of the CMS criteria is really geared towards treating bacterial sepsis, but there's a lot of nuance to it as well. So even though we're using a standardized set of criteria, there's a lot of room to use our clinical brains here. Basic treatment of sepsis involves early fluid resuscitation, early administration of broad-spectrum antibiotics after blood cultures have been drawn, and then, like we said in the beginning, extensive laboratory analysis, including serum lactate. This is all in the context of source identification. So again, for labs and source identification, you're going to want to run your standard CBC, CMP, lipase. You're going to want to be looking at other sources of infection, so a chest x-ray for community-acquired pneumonia, urinalysis, other body fluid analysis. So if someone has a hot red joint, you might want to tap that joint. If they have abdominal pain, you might be looking at a CT scan for appendicitis or cholecystitis. In terms of the interventions, for severe sepsis, we're going to be bringing down that fever with something like acetaminophen. Once they meet severe sepsis, we'll be administering a 30 cc per kilogram crystalloid bolus. That can be normal saline or lactated ringers. And then after blood cultures have been drawn, broad spectrum antibiotics. And of course, a full body infection is painful. You'll want to be focused on pain control as well. And if unfortunately your patient progresses to septic shock, where they have a MAP less than 65 or a systolic blood pressure less than 90 cc's per milligram of mercury, you are going to want to be frequently reassessing perfusion status, remeasuring those lactate levels to gauge your resuscitation, and more importantly, starting vasopressors. So obviously there's a lot more to learn about sepsis. We're going to be wrapping it up here. But we at WHA are producing these 5 or 10-minute videos at our members' request to provide a quick overview of admittedly complicated topics. Additional resources are available in the subsequent videos and also at the WHA Quality Center website or the Michigan Hospital Association community page. I'm going to leave it there. Good luck treating sepsis, and be sure to check out our other videos.